Good day, everyone, and welcome. I'm Jack Van Horn from the University of Virginia, and I am very proud to welcome you to this edition of our 2022-2023 Foundations of Biomedical Data Science Seminar Series. This lecture series is supported by UVA's Integrated Translational Health Institute of Virginia, the UVA Brain Institute, the College of Arts and Sciences, the School of Data Science, and through grants from the National Institutes of General Medical Sciences. Since 2016, the Foundations of Biomedical Data Science Seminar Series has been focusing on the use of data science methodologies, artificial intelligence, deep learning, and statistical modeling as they pertain to differing themes in the biomedical and health sciences. This year's theme is data science and the public health consequences of the COVID-19 pandemic, where each Friday we enjoy presentations from leading thinkers about the issues, the promises, the opportunities, and the hurdles associated with understanding the secondary health effects of COVID-19. These include delayed health checkups, delayed treatments, mental health, drug abuse, increased obesity, and the long lingering health effects associated with the SARS-CoV-19 virus. Participants selected for our Biomedical Data Science Innovation Lab program will leverage these presentations as vital material in our culminating in-person grant project development workshop to be held at the Lodge at St. Edwards Park in Seattle, Washington in June of 2023. Today, I am delighted to welcome our speaker, Dr. Mike Famulare, Senior Research Manager and Head of the EPI team at the Institute for Disease Model, which is an institute within global health at the Bill and Melinda Gates Foundation. Mike is core discipline is using mathematical modeling to study infectious disease transmission and to improve the utility of disease surveillance data. Since joining IDM in 2012, he has been working closely with partners in the Global Polio Eradication Initiative to assess the impacts of polio vaccination policies. He is also a co-founding principal investigator of the Seattle Flu Study, an innovative, collaborative, and in-home multi-pathogen self-testing that identified the first case of community transmission of COVID-19 in the United States. In 2020 and 2021, he co-led IDM's COVID-19 response with a focus on analytics and modeling to inform COVID-19 control strategies in collaboration with the Washington State Department of Health and with Governor Inslee in Washington State. His current teams and personal research are focused mostly on pathogen environmental surveillance, phylogenetic and inference methods, evolutionary epidemiology of the poliovirus, and immunological modeling and transmission in epidemiology. In continuing with the 2022-2023 Biomedical Data Science Seminar Series theme, Mike's lecture today is entitled Choices Give Meaning to Uncertainty, Stories from Pandemic Emergence, Policy Advising, and a Very Personalized Medicine. In his talk, Mike is going to discuss these issues in the context of his work on pandemic emergence, policy advising, and as a person living with multiple sclerosis forced to navigate the trade-offs in COVID prevention and MS care. As always, we are streaming this lecture live and for recording via YouTube. And if you are watching on YouTube, thank you for joining us. Also, our specially selected 2022-2023 Biomedical Data Science Innovation Lab participants and alumni are encouraged to submit any questions they have for Mike via the chat feature in their Zoom sessions. I'll synthesize these questions and ask them on your behalf during the last 10 minutes or so of the lecture. And with that, welcome, Mike. We are really excited to hear about your work, your progress, and your personal story. Thank you, Mike.
Thank you. Thank you for that excellent introduction. So before diving in, I just want to tell you a little bit about our research institute because we're somewhat unique in the global health landscape. So I'm in a place called the Institute for Disease Modeling, which as of the summer of 2020 is a research institute within the Bill and Melinda Gates Foundation. Prior to that, we were in a global good philanthropic investment fund over at Intellectual Ventures. And when the COVID pandemic started, I wasn't yet in the Gates Foundation, but I was still at IDM. Our mission is to shape global efforts to eradicate infectious disease and to achieve permanent improvements in health for those most in need. It's a multidisciplinary team of about 90 people. We have a core of research scientists, software engineers, there's technical writing, project management, admin, IT, the whole body of work for technical work together. As I mentioned, we're now an embedded research institute within BMGF. We support researchers and policymakers in global health, and part of our mission is to develop computational tools to support that. While we're part of the Bill and Melinda Gates Foundation, Institute for Disease Modeling is not a funder. We are a research partner. You can think of us as intramural research. We work with a wide ecosystem of partners. It's universities, other NGOs, government ministries, research, public health institutions, and partner with the grant-making divisions of BMGF in certain ways. Also, just to call out for those of you who have postdocs or students looking to graduate, we are just now opening a few new roles in mathematical modeling. The first one in enteric disease modeling is up as of a week ago. Over the next month or 2 or 3, there'll probably be 3-ish more. So yeah, keep an eye out on that and let us know if you're interested. Because I'm bad at doing acknowledgements at the end because the momentum carries me away, I wanted to highlight a small selection of people that were very close to some of the stories we'll talk about today. On the left are colleagues from mostly Institute for Disease Modeling and Bill Melinda Gates Foundation. And on the right are many of our external partners, both in government and in academic research. Some folks you might have heard of, like Trevor Bedford, Governor Inslee, but also many other folks as well. I'm going to tell stories today from a fairly personal perspective in the context of science, because I want to share that part of the process and how the doing of science is affected by how I think about the doing of science. And for folks that are trying to develop their careers right now and pick their direction, I want to model something that I don't see talked about enough and that I value here. And so, but whenever I say I'm almost always with talking about a we. So with that in mind, what's this talk about? The teaser from Gianna was lectures can be on any topic you prefer that's related to the secondary consequences of COVID-19 pandemic or the data science challenges associated with it. As I mentioned, I've taken that to sort of as an opportunity to give a talk that balances some technical material and what did we do as modelers with some of the personal aspects of doing that work. As in the framing, the title, right, really what I want this talk is about is uncertainty, right? That is the story of the pandemic, especially early on. Thinking clearly through uncertainty, that's a skill, there's principles, there's ways of going about it. And importantly, decision-making under uncertainty, because that was the key challenge, or one of the key challenges of the pandemic. Along the way, I'm going to be open about some challenges that I think we collectively face as individuals that I also personally have faced. And, I'm going to be a bit normative about what I think are our responsibilities as scientists in a way that is probably not quite becoming of a person of my age, but for which I feel very strongly and want to use this opportunity. I hope, the mindset I'm hoping you can be in is, one, enjoy some stories. I'm not going to be terribly detailed technically, at least in the way my brain works. I hope you can enjoy that. Also, throughout COVID, throughout everything, we have people who pose as experts. I am going to pose as a very confident expert. At times, you should be evaluating my credibility. And also thinking about what that would be like as a colleague. And I hope then some of the reflectiveness of this talk helps you reflect on your work in relation to society, in relation to the program that you're in. Okay, more specifically, right? I want to try to put you in my shoes during 3 critical periods during the pandemic. First, starting in January, figuring out the dynamics and epidemiology of what was then 2019 nCoV. From there, a little bit on what I think I came to understand was our work in the interaction between science and public and government of building a shared mental model. That being a point that I'll come back to, very important. And last, I take this opportunity to say something that I don't think we talk about enough. I had a unique perspective on personalized medicine as an immunocompromised person. I have multiple sclerosis. I was diagnosed back in grad school. I kept it to myself professionally until the March 1st of 2020, when I decided to tell my bosses, because I did not know what my life was going to be like during a pandemic. And have since felt that, people like me got to talk. And so there's some interesting science in this. And I wanted to share the interesting science part of that, where I have the unique fortune of having been both an expert in COVID-19 and a person having to navigate their own care for a complex disease. I hope this takes away some illustrated general principles. And I hope it prompts reflection. And to be clear, I'm expressing my own opinions from my own experience. Nothing I'll say today is an official position of the Bill Melinda Gates Foundation. All right, so it's January 2020, and you read the news, strange pneumonia out of Wuhan, right? So this is the situation I want you to sort of put your imagination into. You know, you, like me, you want to know what's happening and what's going to happen, right? Why? First, foremost, you know, we're compelled as scientists. Something appears to be unique, serious, and real is happening in our domain of expertise, and that is, you know, of deep motivation, just intrinsically for me. And in my case, also my work is related. I was working in pandemic preparedness before this happened. I was co-PI of what at the time was the largest respiratory surveillance study in the country, with the Seattle flu study. We had started in 2018 to develop a integrated testing, data analysis, multi-pathogen surveillance platform in the Seattle metro area, coupled with hospitals and, you know, at-home testing where you got a swab sent to your house and a courier brought it back, and a day and a half later you had a result if you were positive for something. All of that started in November of 2018, and so we were trying to demonstrate what could you do with the infrastructure available in the United States if you had the funding of a Bill Gates to support, where the funding wasn't the problem, but all the problems were going to be how do you wire that up in this environment? You know, so that was, of course, professional interest. So, but beyond that, though, for all of us, you know, things I want to highlight is like an important question is like there's something compelling happen, but like, are we capable of helping? And I honestly think that's a question that not nearly enough people ask themselves, as we'll, you know, as we see later. You know, do you have relevant research program, right? You have the expertise. Something else that I thought was really important, and I saw lots of different behavior. Do you want to help any way you can when something like this happens? Including, you know, the metaphorical equivalent of filling sandbags. Like maybe you don't get to be the expert right now, but there's something you can do. You're good at plumbing and data science, or you're willing to grunt write a report, even though you wish you were giving the TV talk, whatever. Like, you know, is that where you were okay with entering? That's a choice. Alternatively, like you have a thing you love to do, you have a thing you're really good at. You know, do you want to find your niche in this now disrupted ecosystem? That's also a very valid choice. People made that choice well, but it's a different way of engagement. You have different expectations for what you're going to be involved in. As I mentioned before, you know, you got to do the work. Pontificating because you read some abstracts is not good enough. Are you going to do the grunt work of knowing the thing before opening your mouth? Related, living with scientific discomfort, living with the risk of being wrong. I'll just say for me, that was a huge change. At the Institute for Disease Modeling, we often partner in, you know, in a relatively silent way in the past, would work with, I would have a small role with a couple WHO committees that serve the Global Polio Eradication Program, and, you know, write a handful of papers and mostly internal PowerPoints that go into decision-making meetings, and, you know, quite invisible. But all of a sudden finding yourself in the position to have to speak in a very public way was a huge transition emotionally. Of course, also important is, can you pay for it? You want to pivot, can we pay for it? The question I think to ask as you're building your career now is, you know, how do you position yourself so that that's easier if you want to do this kind of work? I was fortunate to have a very flexible funding model in my institute. We have hard salaries. We're not closely tied to grants. So I trusted to pivot based on my judgment. Not everyone has that privilege. Other labs, their work was closer to this. They were able to pivot, and there were other labs that pivoted even though they couldn't pay for it. Hoped the best would happen, and some that, you know, people I know personally that could have done very good work that could not support their lab if they made a significant pivot and had to accept that. And the last point that I don't think enough people talked about is, you know, why are you really doing this? You know, it's, you know, you want to help, or you're just afraid of missing out and you want to have a stage. So, you know, from that big picture, I want to give you a feel of what it was actually like in the English speaking world starting right around January 1st, 2020. You know, but yeah, I think on like the Saturday after New Year's, I opened up my Feedly and read some of the flu blog community, and, you know, saw a strange pneumonia in Wuhan, and was like, you know, came back to work on a Monday and kept reading. And by the middle of that first week of January, was like, oh shit, there's something happening. Very quickly, other people did this, and there was this remarkable thing that I have not seen this story told very well from this early, where a small but dedicated group of volunteers created data out of news. They created analyzable data out of social media posts. And there were these lineless efforts. There was probably, I think, 3 or 4 of them, one of which turned into Johns Hopkins effort. Another, also inspired the US COVID tracking project that came out of the Atlantic. But people were taking, either they were native Mandarin readers or using Google Translate, taking official reports from official social media mouthpieces mostly on Weibo, of case reports that were often quite detailed in the beginning, putting that into open Google spreadsheets that had a bunch of information: symptom onset, hospitalization. Was there a known exposure? Travelers that had been to Wuhan and left had an exposure window that you could actually use to help understand the infection progression. This was an enormously useful resource, and this was an example of something that people just did. It filled a massive hole in global public health infrastructure, and enabled people like me, sitting in the comfort of my home in the Seattle area, to start not just reading what was happening, but start engaging with it as a scientist, engaging with it specifically as a mathematical modeler of infectious disease who had a whole bunch of things he wanted to know about this disease. And just a quote from, I think, early February that I got permission to share, from my memory, of a colleague of mine, David Piggott at UW. Once the case numbers were bigger, this was now international, the effort that he was part of, he goes, "I spent last night watching Schitt's Creek and adding 10,000 cases to the line list." Like, that was what that became. And why this is so important is it enabled people like myself to learn about the disease very quickly. And in fact, often, honestly, a week before even the fastest papers came out. So I'm showing here just a whiteboard figure from January 29th of 2020. You can see my sort of portly frame shadowed in the middle of it. I took a picture after this meeting, where I sketched out our best guess on what was the entire acute disease course of COVID-19. And that was mostly informed by the line list and a couple of papers that had come out. We knew things like that the latent period before you would start shedding virus was, 2 to 5 days. You shed probably for 7 to 21 more. Your infectiousness for a big peak of that was stuff that we could guess from either exposure data or knowing other viruses. In analogy with other viruses, we could guess the shape of what the viral titer must have looked like before there was not a single measurement, just under the assumption that, oh wait, this is probably working like a transmission. This is looking like a flu virus, just longer. Oh, it's not looking like SARS-1, which had a different shape, because we're seeing evidence of transmission from people who are not very sick. Mapping that onto the symptomatic course in the bottom, the blue incubation period, acute symptomatic versus severe. One of the things that was really obvious reading the case reports yourself was when people talked about symptomatic, COVID back then, they were talking about 2 things, and you could see it. They were talking about, you got a fever, cough, and then they were also talking about you're about to die and you went to the hospital. And so from that, you could parse that, that 4 to 14 days estimate was often clouding 2 different things, and parsing that apart helped you understand the progression. Also importantly, and I've drawn on this figure, is the transition from incubation of symptoms to acute symptoms with the first blue bar. I've drawn about a day after what I thought was the rapid rise in viral titer. That was a guess because by late January, it was already clear that there was pre or asymptomatic transmission from a handful of case reports. There was reports of a restaurant in Wuhan. There were a couple of Japanese tour bus drivers who got sick from, people on the bus, despite being, behind a glass partition. And so this was known. And I want you to reflect on what came later. So many people who did not know because they did not do the work early enough. And in March, they were talking about stuff that they didn't know. From the line lists, we could also understand a lot of case fatality, even just from the early cases. This is showing data from, I don't know, this is probably, if I remember correctly, like 100 and maybe 100 cases, from January 15th and earlier. Already clear was the age gradient in severity. Already clear was you had to deal with strong right censoring as you were watching the outcomes. It took 3 weeks from when you first got infected on average to when people died. And you needed to account for that to understand the severity. And I will say that, this is when we started doing work in public, at least through GitHub, realizing that it didn't if you didn't write it down and put it somewhere, it didn't exist, and it mattered that it was somewhere so people could read it. You know, other things that I want to highlight are, how did we learn about incidence? You know, there was not or prevalence. There was not a lot of testing. Most testing was based on X-rays of lung symptoms. It was very incomplete data. But people were doing really interesting stuff with opportunistic sampling. There were a handful of papers. This is a grab from one of, you know, in the case of international travel, we saw the Wuhan repatriation flights. These are after the Wuhan lockdown started, you know, was starting on January 23rd. People, you know, governments were flying out their citizens and then testing people who on those planes. And from those planes, we got prevalence estimates of approximately 1%. Those were consistent with other estimates that had been done from domestic travel within China by a group from Hong Kong University that was the first to publish on this. And so we started to get a picture of, like, what at the end of January, there was 1-ish% prevalence. And so with 1-ish% prevalence and an understanding of the exponential growth, we could work our way backwards. Other things that are interesting, you know, this was work from the MOBS lab, Alex Vespiani and so on. And I'm showing a snapshot, but there was once a website that was updating this every day. Just again, looking at the flight network and coloring by was a case detected. Something we were able to see here is that the cases were showing up pretty much in proportion to how many flights were leaving China. And you could watch the cases accumulate and land be found first in the countries with the most travel. And so again, you got a picture of what was happening. What's really interesting about this is these flight network modeling approaches, they're often terrible, like quantitatively, they're often poorly predictive. The Ebola outbreak had a number of massive pratfalls by people assuming well-mixed modeling that had no validity, because Ebola is a highly socially contact-driven disease. You know, close contact with acutely ill people and their and funerals. But seeing the simplest models, you know, the front of the epidemiological modeling textbook work over and over again for measurements out of Wuhan, was the kind of thing that we often don't think about how to model, but it's actually really important. If the simplest well-mixing models are working well, that tells you the virus is, at this point in the epidemic early on, doesn't care a lot about social structure. It's not entrenched in specific behavioral patterns. It's kind of confined just about anybody. And that means that the transmission must be easy for the virus, right? Again, it's not SARS-1, it's not Ebola. It also must be hard for people to see. Right? It must not just be acutely ill people, because acutely ill people are not getting on planes at high frequency in proportion to normal travel patterns. So seeing this per population randomness work around the world also gave us a lot of picture about a disease that could easily transmit, for which people, you know, were not acutely aware that they were infecting other people. And that was clear as the most likely thing before even the first unambiguous reports of asymptomatic transmission that came out, you know, a week after what I'm talking about here was available. And so working backwards with prevalence and case fatality, understanding of the disease course, the delays, you know, 3 groups of us independently, myself, one of them, were able to produce the first credible estimates of the infection fatality rate, or came out between like 0.3 and 1% for China. Interesting thing about that 0.3 is the lowest end number was mine, and I actually had an arithmetic mistake that Neil Ferguson caught, and we updated it, and it was closer to 1%. But I'm telling you what was reported as of exactly the day that this report from WHO was made. That, you know, with the age structure, we already were able to think through things like, regardless, if infection goes unchecked, Italy, the second oldest country on Earth, was going to have a hard time. Japan, first oldest country on Earth, would have had a hard time, except for they were very good on infection control from very early on. In contrast, a lot of the conversation about, is there COVID in sub-Saharan Africa? What does that look like? Severe disease, fundamentally important, but early on there was like, oh, all sorts of weird stuff, like people don't get it here. But it was like, we knew they would have a lower mortality rate. It's a much younger age pyramid, and that was all clear from Chinese data that held up since. And so I just want to leave you for a moment with this. This was a figure I prepared. This is the February 19th version. It takes the CDC's flu pandemic ranking system that they had published, I think, right after, like in 2010, and draws what we expect for COVID-19 on it. This is based on infection fatality rate. It's based on the transmissibility. And I think why I wanted to share this is because we all know what came after. We knew what this was going to be. Any person in March 2020 or later who talked of uncertainty about the fatality rate, who talked enormous uncertainty about how many people would get infected if we do nothing, maybe it'll just go away. Modelers who put out models where things peaked in April and deterministically disappeared in June. All of that was incompatible with what was known and published by February of 2020. So every platform person who was talking with less confidence than I am right now was underinformed. And as a field and as a discipline, that's something I still think about. Yeah, so I kind of want to have an interlude here. I'm just sort of thinking about what's going on behind this cloud of stuff, right? You know, I often think about systems thinking, and I've cribbed these points from the Intro to Systems Thinking report from the UK Government Science Office. Systems thinking is a way of exploring and develop effective action by looking at connected wholes rather than separate parts. You know, looking back on that theme of the slides I just showed you, those were each pieces of many variables that go into understanding a disease that work together to understand the whole. Almost nothing I talked about was a representative sample of anything. Most of it barely qualified as a data set in the traditional sense. But there was an enormous amount of evidence, and that evidence through mathematical thinking about how do infectious disease systems interact could allow you to get an accurate picture. And again, the citations hold up. This isn't retrospective. We have the evidence, not just me, the other people who had done this in parallel, people like me around the world. The evidence exists to know you could get it right in the first time. That requires thinking about context and beliefs, right? It's how do people think of the system, because you're going to interact with people. When you say the system, how do you define it with respect to everything else in the universe? You know, it's not just this aspect of disease. It's not just a clinical lens. There's parts. Clinical lens is a part. There's the wholes, the whole thing. There's layers of different scales of parts. Everything is connected. Everything has feedback loops, and on all those connections, parts, holes, layers, there are processes, dynamical processes that propagate what happens, whether it be information, infection, et cetera, through that system. Our research programs are often strongly incentivized to do some part of a system. You become a narrow expert in a deep way. You're good at writing grants to be able to say, like, I'm the person who does this. I know how to do this. We have all the lab equipment to do this. Very valuable work, and that kind of valuable work feeds the system thinking. But I do think in an emergency situation, and I do know that other talks I've watched in the series have brought this up before, you do need systems thinkers in key places. And I think as leaders in the future and thinking about our careers, think about do we want to position ourselves as system thinkers? If so, what do we need to do to be actually good at it, not just to be a thinker, be like actually have the skills. Conversely, if we know that we're not going to position ourselves that way, because our passion is, in my case, in an alternate life, it's the evolutionary virology of polioviruses. If I left global health and went to academia, I would write weird evolutionary bio papers on a nearly extinct virus because I love it. Okay, that's great. Do that. I'm asking you at this, as you think about shaping your career relative to the incentives to do one type of thing, how do you want to relate to the systems around you? Okay. So switching topics or continuing on the story, I pose a provocative question that we did not answer, and I'll tell you how we didn't answer it, but it's March 2020, should Seattle area close schools, right? So my study, Seattle flu study, in early February, we had worked with Thermo Fisher. This was not me. In some ways, I was the least important of the 11-ish principal investigators on this story. But I'd worked with Thermo Fisher to design a SARS-2 assay that we could add on our, multiplexed respiratory disease array. But of course, as everyone I think maybe remembers, no one was allowed to use tests that weren't developed by CDC at that time. So we sat on it for a few weeks, and by late February, third week of February, we were fully aware of how untenable this was. There were cases popping up all over the world. There was, transmission was starting to happen. We're seeing massive outbreaks in Italy. And so we made a decision to start using our test, despite it not having been approved. I think, the thing that I think cut through the fear was Michael Book, who's a professor or researcher at the Fred Hutch Cancer Research Institute, just sort of asking, like, what would a reasonable person think if, we had the information, and that was the clarifying thing. And so with that, we found the first evidence of community transmission in Washington State, and I think contemporaneous, the second, parallel to community transmission identified in California. There was a student that was about to go back to high school and got the phone call at 6 a.m, and that was that. Now, at this point in time, we know we have community transmission, literally miles from my house. And my organization, Institute for Disease Modeling, we started to pivot really aggressively to try to understand this disease as an institute and build software tools that were better than we had to do all sorts of different kinds of modeling to help understand the situation and help understand what would happen. I show here that, sort of the most crude, useful thing we did as a model. This was our first mathematical model of the Seattle area. It was published, this is a report we published on March 10th. It was calibrated to the very little bit of mortality and case data that we had, consistent with what we knew about the disease from mostly out of China. And we were only able to simulate random mixing. We did not have social structure built into the model that looked like Seattle at this point in time. We were not able to model schools in a meaningful way. But we realized that, like, this whole game right now is about decision-making collectively in society. Wuhan and China had shown us that you could use physical distancing to reverse the tide. And so we knew that that was a choice that could be made. And so we made a choice that in the rest of our work on situational awareness, in all the contexts where we were the ones saying, here's what we think is happening, here's what we think could happen, we never showed a forecast. We always showed scenarios with choices, because we knew we were talking to people to say, here's what can happen in your control. And I think that's one of the things that was really important in understanding of COVID, and especially in the beginning, is it was in our control. And to be honest, it still is in our control. And I have heartbreak about that I won't talk about today. Imagine our surprise when the day after we see this figure on TV behind a governor. I never met Governor Inslee at this point in time. We had no relationship with the Department of Health. We were just doing this on spec it helped us learn, and we thought it would be helpful. And we were sharing it with our local contacts in King County, the Seattle area. Immediately after that, public health officials asked us about the work. And we had a big phone meeting with 100 people who knew a hell of a lot more about public health in the United States than I ever did. Very stressful. This was very new. And they asked, what did the modeling say? And we were like, what we can find is if we can cut at least 75% of the transmission links, you'll see prevalence turn around. We had framed it in the context of at one point in terms of like school closures as an option. We didn't model school closures. All we were able to say is we don't know exactly how much something like that would do. We just know that they would be very disruptive across society because of the way contact patterns work. We also knew the businesses, large businesses like Microsoft and Amazon and Boeing had already started telling workers to stay home. And we sort of said, we don't know how to tell you what to do, but we know that if you can figure out how to accomplish this, things will go back. Government, schools, businesses, individuals in the public, they made, shortly after this, they made the decision to close the schools and transmission as much work to home as possible. We were by March 11th, March 12th, this was already well underway. By March 23rd, there was a statewide policy. We were a week, ahead of almost everyone. California was also at the front of the line, and probably saved a few thousand Washingtonians just this. Something really exciting that started to happen afterwards was by putting the work out in public, and then government choosing to put the work out in public even further. It started this process that I don't know how to prove its value, but I believe was really fundamental to some of what went well here. People started using our work as a small piece of their information environment to build their mental model of what was happening. This was a blog post from somebody I never met who starts off with, there's a plot that's been stuck in my brain for about 10 days. And this is on March 25th, which was our plot. And he goes, I'm going to take the data that the Department of Health is putting out and put it on the plot and see if I can figure out what reduction in social distancing have we accomplished, and came to a reasonable conclusion. And it looked like we were following the 25% reduction curve at that point in time. Things were still going up, but they hadn't not going up quite as fast. This was just one person, in a small way, building their own picture with the input of us as scientists. That happened all over. The newspapers worked with government, with us, and did a lot of really good science to say what, the science communication to say this is what people think is happening. Again, our modeling is what I'm highlighting, but there were versions of this from the public health officials, from other research groups, from government, continuing to communicate in our communities, in our state as it grew. This is what we think is happening. It wasn't always here's what I think you should do. That was Governor Inslee's job. Here's what we're going to do. But it was often just what is happening. It was situational awareness over and over again. Seeing that by March, or by the second week, third week of March, that things hadn't turned around yet, a stronger stay-home order was issued, and that bent the peak in Western Washington. And again, and this is our model-based estimates of prevalence, and we probably never hit 1% prevalence, which was to say what Wuhan hit that I was talking about, 2 months earlier. And our modeling, I think, was a small piece of that. And and so I just want to highlight the roles, right? And because this first month, which we were learning as we go, building on a career in public health engagement and global health engagement around the world, but never at this pace and never at this level of stakeholder visibility, media, government, public, the scale of it was totally new. We recognized that we needed our team collectively to stay up to date on the science as much as possible. Having a team that at one point was part-time, 30 people, around 10 people every day, was a huge part of that. That we were incorporating it in the models, mental models at the top scale. How does the world work in a way that I can engage with, that you can engage with? But then also computational, because the computational models put the discipline in the mental models. You can't have one without the other. Computational models that aren't serving some broader understanding are just, they're playing with computer. Conversely, trying to build a mental model that doesn't have any mathematical rubber meets the road pressure is how you get opinions that don't make sense mechanistically, or how you continue to believe something that's no longer possibly true if you've been engaging with the data. We were trying to serve ourselves as scientists. My institute's focus is global health, not domestic health. And so we ended up, because this was an emergency and all hands on deck, we ended up doing a lot of work locally, but that was always in part to serve understanding how we could help people globally in places where the data were not so rich and the relationships not so strong. Part of it was we always shared uncertainty and tried to talk about what that meant. We always enumerated multiple options for the future, as I said, because we're always emphasizing it was a choice. Nothing was predestined. Nothing was guaranteed to occur. You got to pick your adventure. And we would carefully express our opinions, whether when we were requested or when it was part of an ongoing relationship, but we tried hard to not push for personal preferences. Another thing that was really important is it was really clear with our partners and the way we talked to everybody that we interacted with, researchers, media, government, our families. We're learning together as we go. There was no false certainty. There was no, this is how it works. There was no, it was, here's what we understand today. And again, making everything as public as possible. And I've listed a lot of our roles, but actually our partners' roles are in some sense much larger and simpler to list. We were a piece of input. We were part of a relationship network. I don't even know how many other inputs went into how many other people. I don't know, when we worked with Governor Inslee's office over the next 18 months, I have no idea the many other organizations, which ones had what leverage, had what meetings, had what, we were just like, here's what we think is going on scientifically. Let's keep the front edge alive. They take what they value, whether it be someone reading the newspaper, someone reading our report or Twitter, someone making decisions for 8 million people. Whatever else they value, whatever inputs they get, and they are the ones who have the decision to act. They are the ones who act as they see fit. It's our place to help inform. It's our place to honestly communicate when asked what we think we would do. But we have to trust that we don't know. We can't model everything. I don't know if I'm right about everything. And there are lots of choices where I think I would have probably made them differently, where the outcome was better than what I would have made. And so it was really good to know. And so I just want to leave, again, I'm taking way too much credit because I'm just talking about my story. But despite having the first outbreak in the country, Washington State today was 46th per capita in total deaths in the United States. And so not only did things go right at the beginning, but a lot of things stayed right relative to other places. They could have gone more right, but a lot of things went okay. And I think that the shared mental model part that happened a tiny way that we contributed and just the ecosystem here built, I think was a big part of it. Yeah, and so this is something, again, this is, data science and analytics. I really have come to understand that this is the point. This is the point of being a mathematical modeler, is to help people build mental models, help myself do that. Right. Computational modeling is essential for disciplining those models. It's essential for making them specific, mechanistic, for learning how the system actually works, right? You have to, the computational model is incredibly valuable there, but its niche is specifically that. We have to understand there's a small domain of things we can ever model computationally, explicitly, and those are going to interface with things that we don't have the expertise for, or we cannot quantify. And understanding how to make the handoff from those interfaces is an act of learning that one has to engage in deliberately if they want to be good at this. And again, good modeling is useful if it helps people make better decisions, right? It's not about a paper, it's not about cool code. A lot of the modeling we did was way simpler mathematically than we thought it was going to be. There were different kinds of innovations that weren't like the machismo of simulating 1 million people and doing complex interactions, but were like, turning, doing inference of R effective into a deterministic algorithm instead of a stochastic one, so you could run it in a millisecond and do it every day. But most of the actual concepts were quite simple because that's what people needed, it turned out, and knowing you can't do everything, so you have to hand it off to others, and you have to approach others with the expectation that you're going to only give them what you're going to give them and they're going to run with it. And you have to trust that, is how I think about the work that we did, and I think about it going forward, how we will continue to do it when I'm at my best of my ability. Right. So there's one more theme, kind of build a very different scale of the system. I wanted to talk to this audience about my personal experience as somebody living with multiple sclerosis during this pandemic. March 15th, 2020, I have a picture I took of myself. This was a point in time where we were being told masks are either not effective, or if you have them, we have to save the N95s for the healthcare workers. And maybe 1% of my grocery store at this point in time was wearing a mask, and I felt I had to explain myself because it was such a socially disruptive feeling. And so, yeah, here's me with an immunocompromised sign on my shirt, so I can go to Trader Joe's and feel like I'm not going to get harassed. Moving forward, a very scientifically interesting problem that also is personally very relevant. I think the two together means I probably overthought the hell out of this, and you will enjoy possibly thinking about that. So the treatment that I use for multiple sclerosis, one of the more effective ones, or more effective families, are B-cell depleting therapies. They eradicate most of your B cells, which are the antibody-producing cells, and that reduces the progression of MS, because MS is mediated, we now know, by Epstein-Barr virus, which, as an aside, MS is long Epstein-Barr. So something to think about, a chronic disease arising from viral infection. But regardless, I'm immunocompromised. This is known back then to blunt vaccine responses, but it was not. We never had a novel antigen. People get MS as adults. You've seen flu before. You've seen RSV before. And so we knew blunted, but we didn't know how zero. But we're probably at higher risk of severe COVID-19. But by February 21, it was clear that it was not a lot higher. A factor of 2 to 4. Thankfully, not a factor of 30 for if you get infected. you're going to end up in a hospital or dead. But the decision I have to make is I'm due for my next treatment, which is going to deplete my B cells again. In February 2021, vaccines are here, but I don't yet know when I'll be eligible. Of course, the standard of care is the neurologists think about neurology and the public health people think about COVID, and never the twain shall meet. They happen to intersect in my body. Professionally, I'm up to date. I will have no data. There's no one can tell me what the vaccine effectiveness for people like me will be. So my choices, right, are I can change my treatment. I can try to get my B cells back at elevated risk for my MS, which will last. If that damage will usually only partially recovers. I can also vaccinate whether my B cells are depleted or not, and see what happens, because we don't know 100% what's going to happen, right? So I have to break down the problem, right? I don't have the studies. So there's immunology. I'm going to go a little faster now. There's my MS progression. So what can I predict about the vaccine? What can I predict about the interaction of vaccine and my medicine? What can I predict if I change my medicine? What happens to my MS? The key thing for decision making under uncertainty is, what do I value? What am I more afraid of? What will I feel stupider about if it goes wrong? These were things I had to ask. And then, of course, my decisions again. While I'm saying a lot doesn't exist, there was an amazing paper by some real experts in MS immunology that they wrote in 2020, describing, based on what we understand about the immune system, this is probably how this will work. That was very helpful for covering not the emotional parts of these issues, not the values-driven parts of these issues, but the scientific parts, and largely got it all correct before we had even vaccines. So if you want to read one on this topic, go look up the Baker 2020 paper on COVID vaccine readiness. So yeah, we have data. I'm going to skip through this for time, get to the last point. The data helped me make some information. I can calculate stuff about MS risk. I can calculate stuff about COVID risk. I'm in the position of living in a place where we have good estimates of COVID prevalence because my team is making them. But it comes down to the decision I decide, my fears are, is MS going to put me in the hospital, or is COVID going to put me in the hospital? Given what I know of my exposure and the data on literature on both diseases. The uncertainty is huge. These are calculations of multiplied relative risks. Would you believe they came out to within a factor of 2? They were exactly the same. That meant if the decision was entirely about what I valued, hope for, and fear. And that's actually, I think, why I wanted to tell this story, because so much of decision-making under uncertainty is exactly about that. And there's the interlude, right? There's rarely an answer, or rather, there's often no answer to the question you wish was the right one to ask. I wanted something to tell me you should delay your vaccine and do your medicine today, or you should do your medicine, delay your medicine and do your vaccine as soon as you can, whatever. The data, there was no, that had to turn, the answer could have came out that way, but it didn't, right? And that's the thing, there are easy decisions in life. There are things where the outcomes are totally dichotomous. And by dichotomous, I mean the uncertainty is small relative to the difference. It's easy to know one versus the other and pick. This fell into the class of what I might call a hard, easy decision, right? So the second type is the MS one, the minor differences in outcome. It felt like this decision mattered, but given the information, either choice was pretty much rational. There's also a thing that I think a lot of us didn't do the way I would have done during the pandemic, to bad effect. You can have a ton of uncertainty, but enormously asymmetric outcomes. These decisions should be easy. The asymmetric outcome that can happen dominates the risk. These are places where the agita we feel under all that uncertainty often has a lot more to do with wanting to be in control than actually needing more information. There are actually hard decisions too. You have an important decision. Outcomes are meaningfully different, and you don't have the evidence. There are things called wicked problems, which there's a great article on Wikipedia, look up that term. It's about things where there's the answer to the question, how you ask the question changes the answer. The answer changes the next question. People disagree on values, and also just personally overcoming your strong beliefs. A lot of COVID disagreement was about these things, which are not data disagreements. These are values disagreements. It's only this one that's actually a science problem. And understanding those is important. So, yeah. And so one of the things that we often took away for our own work and for sharing with our policy partners is, if you have a decision you can't make, can you figure out a different way to ask the question, or a different way to approach how you might do something that would help the world change so that you could answer the question? You're trying to avoid hard questions is an important art. So I will tell you with the last minute or two that I want to take here before I open up for questions, the decisions I made, I had 3 rounds of this. So I decided I didn't know when vaccine was coming, so I went with standard of care. I got my MS treatment. I got standard of care. After knowing that my vaccine didn't work very well, I got no antibody response. The next round, I delayed treatment. I took advantage of lax record keeping to start over, even though that wasn't the policy. It should be the policy, but it wasn't. In my opinion, it should be the policy. And so I got better than standard of care for what I value. I got the maximum possible vaccine response, and my MS held steady. Interestingly, I developed a mild eczema, which is an autoimmune reaction, something to think about. Did the same thing again, delayed, updated. COVID exposure risk had changed a lot. Omicron changed things a lot. I got a met outcome. I got the best vaccine response, but I had a bit of an MS relapse that's only 80% recovered. It's not severe, but that last 20% is probably going to stay with me the rest of my life. And by this point in time, I had known how to control my exposure pretty well, and I don't have kids yet. And so I don't know if that was the right choice. I'm going to save the reflections. I will leave a question for you of, was it ethical for me, a wealthy white person working for a global health philanthropy that's at a complex place in the global vaccine equity landscape, to take advantage of lax record keeping and get some extra doses? I have my answer to that. I think is a question you guys might enjoy thinking about. Kind of to get to the point here is, this was my personal story that lives in a very unique place in my personal skill set. But there are millions of people with this kind of situation, autoimmune diseases in particular. Personalized medicine, we often talk about genomics. This is about risk factor relative risk, for which much of the data that you need to make these kind of decisions is actually created by the scientific process. I would love to see whether it be a large institution or academic program or pharma, to take on the challenge of not just a drug development, but a decision-making system development, because there is a approach for randomized clinical trials of the treatment process that could help people with doctors say, what do you value when you have these competing risks? Here's what we know about the competing risks and the weights that we would apply to them given your values. Here's how you think you can make a decision. And I bet you we figured out how we could do that with a better than standard of care, both in terms of lower clinical morbidity and improved patient satisfaction. I think this is a really fruitful area for the next 30 years of biomedical data science that is only just beginning to be poked at in a quantitative way. So to wrap up, I'll leave you here. What do I hope to leave you with? Right. Much of the story was about the intersection between different kinds of science that we do on the regular. Right. And as data scientists, we often try to say, here's the data I have, here's the question, what's the answer within my data? That's alone is bad. Often that doesn't give you the right kind of answer. We descend from the natural philosophers, right? It's often tempting to think on, here's how I think the world works. What evidence supports my model? That alone is bad. Similarly, as human animals, right, we often say, here's what I think, and this is what we should do. Those are often proxies for actually I'm avoiding what I feel, and I want us to do this thing I hope will make me feel differently. Some of my MS decisions were like that, and I think that's very worthy of love and compassion. But if your motivation that really this is about feelings is why you're so certain is obscured, that's not a sound basis for action. Yet, as scientists, as individuals, maintaining a dynamic balance on top of all of these and other selves, that's essential to doing our job to the best of our ability. And I don't think we talk about it enough. And that's why I took the chance to do this today. So thank you.
Mike, thank you so much. As you were talking, I was just thinking about some of those early news reports that were, coming out on the national news, where it just looked like Seattle was on fire with COVID in those early days. And this was so worrying. And as we were talking about before we got started, I have family there and in Seattle. And so it was like, it must have been absolutely frightening on the one hand, because you're there at, in the hot zone, as it were, you're seeing it happen in real time. you have a responsibility as a scientist to be taking these data and to be, turning them into something that's actionable. At the same time, you're a person with a particular health concern, and you must have been absolutely terrified. And I was wondering how, in that position, you were able to kind of get that dispassionate kind of distance between maybe where your personal concern, to basically put the focus on the task at hand and to, marshal that, internal fortitude to be able to go and do your job. How did you manage to do that? Because that must have been scary as heck.
Thank you for asking that question. I almost started crying when you asked it. The fully honest and short answer, I guess there's kind of two parts to it. One is something I started unpacking in therapy starting in April 2020 is, I had my family growing up had stuff that I didn't fully understand that seemed normal, that worked together such that I'm one of those people that gets calm when things get stressful. I someone who's overtrained to try to solve other people's problems and figure out what is going on and how I can help. And so there was a sense as like the enormous pressure was building inside of me. I was probably too good, to be honest, at suppressing everything. But then the other thing that happened is like, something I still reflect on is like, in February 24th, we hadn't started using the COVID tests on the, hundreds of respiratory samples a day we were collecting with the flu study. But, I was, 99% sure COVID was somewhere circulating in the United States. The next night, we run the first batch of tests and 1 out of 400 on the, are positive. The difference between 99% sure and 100% sure felt way bigger than I ever thought it would. And the next 3 weeks were the most lucid of my life. All sorts of things. I mean, like, because everything was the most important thing. It was actually really clear and my mind was really quiet. And it was weird stuff. Like my mother-in-law is a February 29th birthday. And my knowledge of the local epidemic started on February 26th or 27th, if I remember correctly. But the public knowledge hadn't yet. And we had planned, and as a February 29th birthday, it was her 19th leap year birthday as a 76-year-old. And there was a large dinner planned at a restaurant. And I remember thinking, the prevalence in this area is less than 1 in 1,000, and there will not be 1,000 people at this restaurant. We're not going to cancel this dinner. Knowing that next week we were going to never go to a restaurant again, and knowing that in February when nobody else did. But why I bring that up is it was really easy to like be present at that dinner because that was the most important thing for that 5 hours. And later that night, we got calls from a New York Times reporter, which I'd never talked to before because Trevor Bedford had tweeted out what we thought was happening. And that was the easiest thing to do because it was scary, but it was like in my father-in-law's office. And that worked for 3 weeks. And as soon as the team around me really spun up and we had 30 people working together and the state had spun up and the public health relationships and the pressure came off a little bit, I had a moment to relax. I psychologically tore myself apart. I was a mess. I was impossible to live with. It was like the foot was on the gas, but the load had eased off and the engine was ripping itself apart. And so that's the honest answer.
It's an incredible story. One of the things that one of our listeners is curious about, now we're kind of on the downslope of COVID and the emergency declarations are ending at the state and federal levels. And it's a lot of people who are in positions as modelers or data scientists working in this space are either losing interest in this area because it's not, hot air, not the hot area anymore, or they're being made redundant because of the jobs going away. What do you think are some of the best uses of the modeling time and resources during this, what they refer to as a relative peacetime?
Yeah, that's a great question. It's one that we're struggling with. Our effort at IDM is down to skeleton crew, and honestly, mine is down to almost zero. The way that I'm thinking about this long term is there are lots of different challenges. Putting the effort into building relationships with people who make decisions, building relationships with your public health colleagues that are on the things that they are actively caring about, being flexible about your disease expertise, but being, being committed to your partnership and decision making or modeling niche expertise are the places that I want us to see us grow as a field, because that's what'll be sustainable, and that's also what positions you to be reactive effectively. We were able to be reactive effectively because my institute was focused on working in partnership across global health. We had a lot of experience. How you figure out how to write that into funding proposals while not losing the scientific knowledge that's required to pivot is a challenge I don't think I don't think I know how to tell you how to solve. But it's really, it's putting partnerships ahead of viruses is, I think, the more sustainable pathway here.
Right. Well, Mike, I want to thank you so much for sharing your experience with us, really at just the front lines of the COVID-19 pandemic in our country, kind of watching it happen in real time in those early days, and kind of developing some of these models, which really spearheaded a lot of interest in doing this at this kind of scale. Being in that position, making models with limited information and then trying to improve upon them must have been a very exciting but fraught and emotional time for you personally. And I want to thank you for sharing your story with us. It's really inspirational. So thank you.
Thank you very much. And thank you everyone for listening. I hope you have stuff you can take away from it to reflect on for yourselves. And I appreciate the share.
Thank you, Mike. And everyone have a wonderful weekend, and we'll see you next week. Bye-bye now.
Bye.